Hey everyone, big news! We've launched a brand new Beyond the Mask website, professionally redesigned to give you a better experience. It's easier to navigate, better organized, and makes it simple to find episodes, explore our exclusive series, and access helpful resources for CRNAs, including CE credits and the 1099 CRNA Institute. Check it out at beyondthemaskpodcast.com. CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to the Beyond the Mask podcast. This is the Anesthesia Alchemy edition. Join hosts Gary Bridges and Lynn Maxey as they deep dive into today's most important clinical conversations.
All right. Well, welcome back, everyone, to Anesthesia Alchemy, Lynn and Gary Unplugged. Now, I'm Gary, and today's episode is going to be a little bit different from our usual format. Lynn's out today, so I'm taking the opportunity to kind of slow things down and really dig into maybe a topic that doesn't really lend itself to quick summaries or even surface-level discussions. Now, today we're talking about anesthesia for cytoreductive surgery with hyperthermic intraperitoneal chemotherapy, also known as HIPEC. Now, these are starting to garner a little bit more traction, I guess, across the United States. I've been doing it for about 25 years. And I want to be very clear, right from the start, that this is not just another big case, if you will. This is one of those most physiologically complex anesthetics that you're probably ever going to manage in your career. They are definitely long cases. They're very dynamic, hemodynamically, as well as all the things that we're going to discuss today. And it does require a little bit of a level of anticipation and vigilance that goes way beyond most cases' demands, if you will. Now, this is not a case where you can rely on things like patterns of recognition alone. It's not a case where you can settle in after induction and make small adjustments along the way. This requires complete engagement. This is a case where physiology is consistently evolving, sometimes slowly, sometimes abruptly. And if you're not thinking ahead, or if you're not actively anticipating the next phase of events with these cases, you're going to find yourself reacting instead of leading the anesthetic and proactively managing these cases. So today, I'm going to walk through this detailed, not a checklist, it's not bullet points, but a continuous thought process as you're going through and setting up for a HIPEC case. Now, you're reviewing the chart. You might already be thinking through your plan. That's the mindset that we're going to actually stay on for this entire episode today. All right, so let's first talk about how we really need to understand the procedure in a more deep context other than putting some chemotherapy into somebody's abdomen and shaking it around for 60 to 90 minutes. So let's begin by really understanding what's happening surgically, because everything we do as anesthesia providers is a downstream of that surgical intervention. Cytoreductive surgery is not a single maneuver. It's a series of aggressive surgical steps really aimed at removing all of the visible tumor in the abdomen from peritoneal cavity. That can involve multi-organ systems. It can involve a bowel resection at the same time, peritoneal stripping, diaphragmatic resections, omentectomies, and sometimes even the spleen or the liver will require some resection. And I have recently seen some aggressive bladder work, as well as in females. They may do a modified hysterectomy or oophorectomy. So these are pretty significant cytoreductive procedures. It is truly a major surgery in the truest sense of the word itself, and importantly, it's a prolonged procedure. Once all that cytoreduction is done, and that part can actually last 6, 8, 10 hours or more, just depending on how profuse or diffuse the Cytoreduction is lysis of adhesions if it's repeat surgeries. These can be really, really lengthy cases. And then you have, depending on the chemotherapy you're using, 60 to 90 minutes of the hyperthermic perfusion. Now, after all that, the patient has already been through hours of surgical stress. And we then move into, if we deem that the patient is a candidate for the HIPEC phase. And that's where, they take chemotherapy, they heat it up, and it's circulated through abdominal cavities. Now, the temperature is usually elevated deliberately. Now, historically, it's been in the low 40s centigrade, and that's causes the hyperthermia, actually enhances sort of the cytotoxic effect of the chemotherapy. Now, I will tell you, we have changed our practice at our facility probably 5 or 6 years ago, maybe a little bit longer. I think it was pre-pandemic. We don't heat the chemo or the patient up to 40 degrees centigrade now. The target, before we start the infusion, or the perfusion rather, is 38.5 degrees centigrade. And the attempt is to hold that temperature of the perfusate and the patient's body temperature to 38.5 degrees centigrade for at least 30 minutes, if not the duration of the perfusion. And that is just as, when we look at the research and the literature, it's just as comparable as far as outcomes compared to when we used to actually increase it to 40 degrees centigrade. If you do increase the perfusate and the patient's body temperature to 40 degrees centigrade, then you have to go through this rigmarole. Pack the head in ice, pack the armpits, pack the groin area, the legs, as many of the back of the shoulders, all in ice packs, so that it preserves the brain function and we're not heating up the brain and stuff like that. And the good news, certainly in our practice, is now that 38.5 degrees centigrade works, then we don't have to do all that packing, which is outstanding. But here's a key shift in the thinking. From a surgical perspective, HIPEC is about cancer treatment. From an anesthetic perspective, in our world, HIPEC is really controlling that systemic stress. And because while the chemotherapy is delivered locally, the physiologic effects are definitely systemic. And those of you that have done these know exactly what I'm talking about. Because while the chemotherapy is being perfused, heat obviously affects the entire body, the vascular, the whole thing. And that's why I say, like, when you're in sort of the 40 degrees centigrade range, you got to start packing the patient in ice. Thank God we don't have to do that anymore. When we get down to the 38.5. Those physiologic effects are systemic, and you see them throughout the entire duration of the case. And sometimes even when they're doing the cancer debulking, we start to see those things. So, things that come with hyperthermic events is metabolic rate increases, oxygen consumption increases, carbon dioxide production increases, vasodilation occurs, and cardiac output starts to shift. Now, I just said a mouthful there, and we sort of have to sit back and kind of start evaluating now is like each one of these elements, how do we manage each one of those elements proactively before they even happen, and then try to maintain that balance of the patient during the course of the procedure. And here's why that matters really so much. We actually have moved towards ERAS-based guidelines decades ago, and that's for the cytoreductive surgery, HIPEC. And it really highlights a structured perioperative care approach that precisely addresses these high-risk procedures. And as we go through this sort of podcast, we can kind of hone in on some of these, why it's so important. So, as an anesthesia provider, your mental model, if you will, or thinking in time proactively. So, before we talk about specific management strategies, I just really want to pause and emphasize something that I think separates experienced providers from those that encounter cases for the very first time. And it's evident. Even somebody with a little bit of experience is very different than somebody that's been doing it for a couple of decades. And you have to think in time segments, if you will. Not just what is happening right now, but what's already happening, what is happening now, and more importantly, what is about to ensue or what's going to happen next. Sort of keeping all of that in your mind as you're going through or approaching these kinds of cases, because HIPECs really are a time-dependent anesthetic, if you will. So let's walk through that. Now, at the beginning of your case, you induce anesthesia, obviously. That looks fairly routine. Establish your airway, you get your lines in, you hook your patient up to the monitors, and then surgery, begins. A few hours pass, you get fluid loss, depending on the type of cancer it is. Protein is obviously lost through that. If they've got ascites, or certainly if they have these appendiceal cancers, it comes out like buckets of jelly. And then the other big thing here is the inflammatory mediators start to get stimulated a little bit more than usual, and they start to circulate through the body. Now that's going to, push into hemodynamic changes, as well as a few other things that we're going to sort of get into. So at that point, you might still feel a little bit comfortable because nothing's really happening right now. Blood pressure stable, heart rate's acceptable. But what you really need to recognize and start to build towards stability in a proactive approach, right? Because when that HIPEC phase comes, you're going to see some really erratic hemodynamics. And as those physiologic shifts occur, you can get behind very, very easily. I talk about getting behind on fluids, hemodynamics, vasoconstriction or vasodilation, how you're going to monitor all of this stuff, and then when and how are you going to be proactively engaged with it. So the questions are you really prepared when that shift starts to appear or happen, which you'll be able to see on some of your hemodynamic monitor, or are you actually reacting to the events? And I can tell you, I've gotten my butt caught up in a sling getting behind. And it wasn't for the lack of preparation, getting behind because of little human factors. And I'll give you an example. We use, and I'll just name the product, Bear Hugger. I don't know what's gone on with that company in the last year or two, but Bear Huggers are starting to fall apart. That little cardboard flange that you stick the hose into, the adhesive is not capable of holding on for a 10 or a 12-hour case. Frequently coming apart, frequently tearing. And I've actually had conversations with Bear Hugger representatives about that. So here you are sort of jerry-rigging, trying to put tegaderms, trying to actually abate something where you're going to have heat loss because you need this Bear Hugger to function, and all of a sudden now it's falling apart on you. So now you're becoming a Bear Hugger quote-unquote technician while you're trying to manage this massive case. It's just inappropriate. Other things, let's say opening your cart. And if you got to send off blood tubes and stuff, always making sure that your tubes are not expired. Making sure that if you get any replacements for disposable supplies in your operating room, that you know how they function. I'll give you the perfect example of that if you're trying to transfuse blood. Now, there's different products of transfusion tubing, and they fill and function differently. And I know there was a replacement in one of the cases I had started, and I never really was paying attention to because one of my technicians already set the thing up, but it wasn't set up right. Had air in the chamber for the squeeze chamber, so nothing functioned on it. And the time to not be fiddling with that is during the case. All of that needs to be done beforehand.
You've probably wondered at some point, should I stay W-2 or go 1099? And more importantly, what would that mean for my income? AANA has launched a new 1099/W-2 income comparison calculator designed to help you compare W-2 compensation with potential 1099 earnings in just minutes. It also helps you understand how taxes, deductions, and expenses could impact your take-home pay. Visit aana.com/1099 calculator to explore the tool, or check this episode's description for the link. The 1099/W-2 income calculator, helping CRNAs better understand the financial side of their career choices.
Let's start to go into some of the domains that should be going through your head and really start to intensively explore what we should be thinking about. So let's take a look at each physiologic domain. We'll expand it, but in a way that you want to think about it maybe before the case as well as during the case. So in that first one, number one is hemodynamics. Hemodynamics in HIPEC cases are not snapshots in time. It is a story that unfolds continuously over time. And early in the case, the patient might appear stable, blood pressure is acceptable, there's no obvious bleeding, you might feel reassured, but stability early on is very misleading, because cytoreduction, what you're seeing is gradual blood loss, significant third spacing because of those, inflammatory markers now that are circulating throughout the vasculature system. And then you're seeing ongoing fluid shifts. And these fluid shifts will ensue not only intraoperatively, but several days after, up to about 72 hours. And then that's usually where they'll start to peak and then start to come back down. Now, these sort of signs don't really manifest themselves early on. They can, but you need to be watching for it and trying to figure out sort of what's happening. And I will tell you that hidden volume deficit, if you will, depending on, so the two types of chemotherapy that are most used are cisplatin or mitomycin C. Now, typically, the surgeon will make a decision on, extensiveness of the cancer type, as to whether they'll do a 60 or a 90-minute perfusion. Mitomycin C, not too bad. You're still going to have a lot of fluid shifts and have that hidden deficit. That's why it's great to have, goal-directed fluid therapy monitors. The other bear is cisplatin, which is really a major toxin. And so there are things that we have to get ready before we even start that perfusion. And one of those things is sodium thiosulfate. You usually have to run a bolus in 30 minutes before that perfusion starts. And then you start an infusion that will go on the duration onto PACU and then potentially overnight recovery. The other thing with cisplatin that we need to be ready for, and we'll know ahead of time if that's the drug that we're using, is some more renal protection with magnesium sulfate. 2 grams IV bolus is plenty. And then you can also see this, you need to recognize that hidden fluid deficit so that you can keep the intravascular volume optimized so that the kidneys don't take a hit. Because if you get behind, their creatinine will skyrocket within the next 42 hours or 24 hours. And when that happens, a good proportion of those patients, I think it's up where around, I think the literature says 36% will have acute kidney injury. And then another percentage of them, about 11 to 14%, go on to chronic renal failure and actually require dialysis. That's our job, to keep them off of dialysis and not let them have an acute kidney injury, because we have to identify that hidden fluid deficit. So once the HIPEC occurs, you get profound vasodilation, your systemic vascular resistance plummets, so that afterload. And now that same volume status now is no longer sufficient because the pipes have doubled or tripled in size. The hemodynamic profile looks like they're septic, right? They start to get a little tachycardic because you're behind on the fluid volume deficit. They're not optimized. And now they start to creep up. When they were starting with a heart rate of maybe 60s or 70s, now they're into the 90s. That's pretty profound. And then you're starting to give pressures because now you're behind on the volume. And sometimes, if you're that far behind before the perfusion, that is sometimes somewhere around between 4 and 6 liters. It's all dependent on the patient and your evaluation as you're going. So you can get behind really, really fast. And that is one thing you do not want to do. Now that blood pressure starts to fall, you haven't anticipated it because you've kind of not paid attention to that hidden deficit. And if you haven't started to prepare for it, you're now really behind, as I said. And that's why advanced hemodynamic monitoring is not only recommended, it is imperative. Now, relying on intermittent blood pressure alone is not going to be adequate for you. You need that real time. So you need to understand your cardiac output monitoring, your stroke volume variation, your fluid responsiveness. Another one that I do, so you'll have arterial waveform tracing. I usually like to look at the cursor. I'll slow the sweep speed, and then I'll see if, when I'm giving that fluid, am I starting to reduce that variation that you will see? Now, naturally, on some of the monitors like the Edwards and the Lidcos, you'll actually have stroke volume variation. I'm not sure how accurate that is when you got an open cavity and they're pushing around on things. this is an algorithm versus looking at it manually by changing your sweep speed and setting your cursor level at the arterial peaks on the waveform. And then when you're giving the fluid, you can watch that responsiveness. So some of the things that should be going through your head is why is blood pressure low? Is it vasodilation? Is it hypovolemia? Or is it both? And how you manage those. So your treatment is really going to depend on the answer to those two questions. So given that, let's move into filling that tank up, fluid volume management. And, it's precision of volume. You don't want to flood them, but you also don't want that tank anywhere near empty or even half full. So fluid management in these cases are where, a lot of providers start to struggle because you're like, ooh, that's a lot of fluid, and when do you give that fluid, right? And you don't want to be in the scenario of I'm behind 4 liters. Now I got to give 4.5 liters as quickly as possible so I can fill that tank up. You get into those scenarios and then you can overshoot very easily. So now the cytoreductive phase, which is where they're pulling the debulking of the tumor, the patient's losing things like blood, plasma, protein through the ascites because they're just leaking into the abdominal cavity. And you'll find when the surgeons are pulling laps out, they're just saturated. Combination of that, the blood, the plasma, proteins, fluid that fills into the interstitial spaces. And you can start to see that tissue edema start to happen. And so you're trying to minimize that tissue edema. You're obviously not going to be able to abate it, but your fluid resuscitation, you want to make sure that it's not your fluid resuscitation that's technically causing that. That is just manipulation from surgical intervention. So this is not simple deficits. It's a complex redistribution of volume. And, your instinct might be to replace that fluid aggressively. Perhaps that might be appropriate. If it is, it's because you miscalculated that silent deficit, if you will. And if you overcorrect, you will introduce several other problems that will ensue over the course of the next 72 hours. That's things like tissue edema, impaired oxygen diffusion, that's to the wounds, that's through the lungs, increased pulmonary complications, and obviously delayed recovery. So you are constantly walking a thin line in these cases. And that's why goal-directed fluid therapy is emphasized religiously in these cases, because it allows you to respond to the patient's actual physiology rather than relying on fixed formulas, right? The 4-3-2-1 rule or the 4-2-1 rule, which is kind of like out the door. It doesn't even apply here. So questions you're going to ask yourself: how much fluid should I give? Does the patient need fluid now? What kind of fluid am I giving? So I just kind of pause there for a little bit. There's multiple schools of thought, crystalloid versus colloid and blah, blah, blah. So obviously when you're going into these cases, you want to know what the hemoglobin is. And, as you're giving fluid, you're doing hemodilution. And so you're going to drop that hemoglobin. And if the patient is wet on the surgical field, meaning are they oozing blood continuously? It just depends on the tumor type. It depends on the individual patient themselves. So you're keeping an eye on all of this stuff. You're running baseline hemoglobins and hematocrits to make sure that you're not breaching that 9. Now, a hemoglobin between 9 and 10 is perfect if you can maintain that over the course of the procedure, because it keeps them a little bit diluted so that clotting is not an issue, or hyperclotting. Colloid versus crystalloid. Knowing the type of chemotherapy that you're using, the predicted, I wait until the abdomen is open to get a good look of what the surgeons are dealing with. And then I start to run in colloid. So albumin, 25%, and I will run approximately 500 cc's to a liter. And then I'm kind of looking at my fluid responsiveness based on all my hemodynamic parameters, right? The other is I will trickle in crystalloid. I'll go ahead and have my blood product transfusion ready to go. So I'll run that through a warming device so that fluid is coming in warm. We'll get into temperature in a minute here, but you can get behind on temperature really, really fast in these cases. Now, by the time they start doing the cytoreduction and omentectomy and all of this stuff, that's going to be the largest portion of the day, if you will, in many cases. Balancing between crystalloid and colloid is an imperative. The other piece is if you're starting to see leaking and it looks a little more wet than normal. What I mean by that is the blood is oozing out of, areas that they're working. You need to send off coags. And I have had a scenario where I'm watching kind of the surgical, debulking, and all of a sudden it's like, my pressure's kind of going down. The laps are coming out like really saturated with blood. And I'm like, are they really wet or like, and that's where communication with the surgical team is really important. And I had a scenario where we actually sent off the labs, did a whole panel. I got, the fibrinogen, you name it, sent off a tag, and the stuff finally came back. I won't get into all the challenges I had, all the human factors. However, patient's hemoglobin dropped from like 10.7 down into 7. And so I started transfusing PAC cells, FFP, and then our TAG and our fibrinogen and all that stuff came back, and they had a consumption coagulopathy. So then we had to kind of convert. So we started giving the blood products. We gave tranexamic acid, all these things to kind of slow the bleeding down. And so these things can happen, and you really need to be watching, prepared, and knowing where not only your dilution effects from your fluid administration, but what's going on in the field, and can you catch up, and are you fixing what the issue actually is? And bear in mind too, is they're also anticoagulated. So sometimes these patients, for unknown reasons, start to get into coagulopathies, and identifying that as quickly as possible is imperative. Now, let's get to temperature. Temperature management with HIPECs are definitely one of the most dramatic examples how physiology will change over time, because you are, and not every practice has moved to the 38.5 degrees centigrade practice. Many still do the 40 centigrade perfusions. And so you got to be ready for that. Abdomen is open. So let's just talk about that first of all. Abdomen is wide open. You've got upper bear hugger or warming device. You got a lower warming device. And then I usually use a humidivent, and I also use those foil caps to help do anything that I can do to maintain the core body temperature. That includes some warm fluids through the blood tubing and those types of things. Those patients, it will take you all day long just to get their body temperature to 37.5, which is what I try to target for, 37.5 to 37.8. So that when they go in and do the perfusate and get the patient up to 38.5, they have a degree or less to go, which they can usually do that fairly quickly. If you're sitting at 36.5, you may not get to that target temperature. For us, it's 38.5. And if you don't, perfusion is a waste, because if the chemotherapy and the body is not at the temperature for it to actually work and be effective on the remaining cancer cells, it's all for nothing. All right, so forced warming, forced air warming, fluid warmers, minimizing exposure where you can. So that's why I say humidivents and caps, the caps and stuff. And you're doing all of this. It's not just normal thermia. You try to get them to normal thermic, 37, 37.5. And try to slightly push them over as best you can. But, it doesn't take too long. A couple hours later, if you're getting behind on the temperature, you're going to be spending the entire time trying to figure out, how am I going to get this up now? And that body cavity is wide open. So heat loss through evaporation and whatnot is a real thing in these cases, And then you get to the HIPEC portion where you've got the hyperthermia. And now the heat's being added actively to the patient through the chemotherapy. The core temperature starts to rise. And again, if you got to have the perfusionist kind of push it through 2 degrees centigrade, there's a good chance you're not going to get to where you need to be. So just be mindful of that. So you do the hyperthermic. Then once the hyperthermic part is complete, then you want to get them back down to sort of the normal thermia, if you will. And that transition does need to be smooth. So you've got to be a little savvy with it. If you're slow to recognize these kind of shifts, these patients' temperatures, they either can be really difficult to get up to where you want them to be, and for us it's 38.5, or if you have excessive temperatures, let's say you're already at 38, sometimes they start to push through once they start the hyperperfusion, and you'll be up in the 40s in no time at all. And so that's a problem. Hyperthermia, as we all know, increases oxygen consumption. As I said earlier, CO2 production goes up, and hemodynamic stability instability is a reality. So anticipate these kinds of events when you're doing these cases. So obviously, continuous core temperature monitoring is imperative. And throughout the entire case, I do an esophageal temperature. And then typically these cases, patients will have not just a catheter, but they'll have ureteral stents, unilateral or bilateral, for a number of reasons. And one of those is a landmark for the surgeons as they're working and doing the debulking. But I also have, so that bladder temperature from the catheter and then the esophageal. Why is that important? Because when they're doing the tumor debulking, that bladder is wide open to the atmosphere. They're pouring fluids into the cavity sometimes. And so sometimes you can have a 3 or a 4 degree differential between your esophageal core temperature and your bladder core temperature. And so people will say, well, why even bother putting a bladder temperature in? Well, the reason being is so that when the hyperperfusion phase is happening, you know exactly what that temperature of that fluid. It could be something on the dial on the perfusion unit, and then knowing exactly what it is when it's in the body cavity is important. So what else? What are some of the other things that we need to be worried about? Well, let's talk a little bit about respiratory physiology, because that does take a hit. Respiratory mechanics in HIPECs, they don't usually fail suddenly, right? It's a gradual increase in deterioration, if you will. And this is what makes HIPECs so dangerous. These patients can go into respiratory failure quite easily. So, early in the case, ventilation, pretty straightforward. Compliance is reasonable. Oxygenation is typically adequate. But as you start to progress through the cytoreduction, there's movement. And if there's tumor debulking off of the diaphragm, sometimes they penetrate the diaphragm. And so if they penetrate the diaphragm, there's some other issues that goes on. Then you've got abdominal manipulation. You got fluid shifts that are happening. As I said, diaphragmatic movement, or if they're pushing on the liver, sometimes they're resecting off the liver. A lot of manipulation. And I find particularly the diaphragm above the stomach on the left side of the patient tends to be a fair amount of manipulation there. Sometimes they actually resect some of the diaphragm or get inadvertently into the diaphragm as they're trying to debulk some of that tumor off. And, if they're working on some of the liver, sometimes that will have some diaphragmatic penetration too. So be aware of that. With all of these things, you start to see pulmonary compliance start to decrease. And it's just makes sense, right? With all of this controlled trauma, if you will get interstitial fluid accumulation in the lungs. Then you add on the hyperperfusion on top of that, and you start to get increase in metabolic demand. Carbon dioxide production increases. Now ventilation becomes even more difficult. So what do you do in these scenarios? So the protective and the most acceptable strategy in these cases, as far as pulmonary mechanics, is low tidal volumes. You start to gradually turn on PEEP before you start doing the perfusion, and you definitely want to avoid high airway pressures. And where this is all going to be evident is after the hyperperfusion, when they try to close the abdomen, whether it's plastic surgery or whether it's your surgeons that do the HIPEC. As they're closing, look at peak inspiratory pressures. And if they're significant, you need to let that surgeon know, hey, I was running around 17 centimeters of water or millimeters of mercury of peak inspiratory pressures. My compliance is now dropping. And now as you've got the muscle layer closed, now my pips are sitting in around 28 to 30. Starts to be a problem. And so then you got to start thinking like, what do I do now? And so that's a conversation with the surgeon because they're going to manage this postoperatively, not us. So you're constantly reassessing, because certainly during the HIPEC component, your pulmonary mechanics, as I said, are not going to be the same as when they were doing the tumor debulking. And so, using your ventilator parameters, your arterial line, your advanced hemodynamic monitors, all help you sort of address what is needed proactively.
Are you looking to transition into independent practice? AANA and Beyond the Mask are here to help you thrive as your own boss. Visit the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management tailored specifically for 1099 CRNAs. Plus, enjoy a special 20% discount using the code BEYOND1099 at checkout. Visit aana.com/1099 to learn more and start building the future you want. The 1099 CRNA Institute. Thrive as your own boss.
Okay, the next phase, and we talked a little bit about, is coagulation. Coagulopathies, as I said, are not always evident early on, but it is imperative that we sit there and we look into the surgical field and have conversations with that surgical team. How does it look? It looks like they're leaking a little bit too much, or it looks pretty dry. Are you feeling confident? And then you got to be worrying about vasculature stuff, like if they get in over by the cava and they're resecting, the spleen, stuff like that. And that typically coagulopathies are not immediate. They tend to gradually develop over time, but they can be immediate. And that's why it's just imperative that we pay attention the entire time. So you start with surgical bleeding, fluid replacement. Then you start to add on the dilution of clotting factors during these cases, because it's not unreasonable to give 6 liters, 6.5, sometimes 7 liters of fluid, depending on the patient. The temperature affects coagulopathies, right? If you're getting too cold, platelets don't function. If you're getting too hot, you're now got hypermetabolic states. Inflammatory response also has an impact. And now coagulation now becomes impaired. And then it's up to us to figure out, this is the challenge is, it doesn't always show up immediately in the bleeding, and, proactive monitoring. So sending serial labs, if your hemoglobin starts to shift too much, you try to make an educated guess. Is it the surgical field? Is the combination surgical field and my hemodilution? Are we appropriate right now? Or do I need to send off some more labs because it really precipitously dropped and we never got into any vascular stuff? So serial labs, point of care testing, and if you have to send a TEG to really look at coagulation. Now, these patients typically for thromboembolic prophylaxis, we're using heparin, typically 2,500 units to 5,000 units. Some people use low molecular weight heparin. It just depends on your surgeon. But the question is when do you intervene with blood management, right? Sometimes it could be just a unit of packed cells. Sometimes it could be several units of packed cells. Some plasma, fresh frozen plasma. Sometimes you might get to cryoprecipitate, just depending. Sometimes you might have to use DDAVP, Amicar, anything like that. So it's not really about just giving blood or packed cells. You really have to understand what is going on with the patient and how do I assess that clotting cascade as to what area I actually need to intervene with. And I will tell you right now, if you're having management problems and you have coagulopathies that start, I don't know about your facility, but we have the benefit of having a hematologist available. So I will actually make a call to the hematologist and say, take a look at this patient's labs, give me some recommendations. Here's what's going on. And they will even sometimes come right into the operating room to kind of get a feel for what's going on. And I will tell you, more often than not, the recommendation is completely different than what my thought process is. Couple of good things there. Number one, you're using a consultant for their expert advice. Number two, you have a fresh set of eyes that sit there and start to make sense of some of the things that, you're going to get really into a lot of different things and thinking about a lot of different things during these cases. And so it's an imperative to really start to use your experts. And I think your surgeon will thank you for it too, because they're pretty interesting discussions. So at this point, I want you to kind of step back, look at the full picture. We start evaluating the systems like hemodynamics, fluid balance, temperature, ventilation, coagulopathy. They are not independent of one another. They can influence each other. So when we see something change, you have to start thinking systemically. 30,000 foot level. What else could be changing because of what I'm seeing at this point in time? For example, rising temperature increases metabolic demand, increases carbon dioxide production. Ventilatory changes will occur. Fluid overload decreases lung compliance. Ventilatory difficulty is starting to ensue. Hypovolemia, hypotension, organ perfusion concerns, particularly the kidneys. The kidneys will take a massive hit in these cases. Not uncommon to see your creatinine double or triple, but the goal is if you've got them appropriately balanced in fluid and they're pretty much as close to euvolemic or a little slightly like a plus 1 liter positive, you will likely minimize the amount of that creatinine bump. But if you get behind and you start seeing hypoperfusion, hypotension, and you're struggling with that, here's the key. If you've got to treat that more than, a few times with a pressor, it is better, and you're starting to see these swings in hemodynamics. Now, assuming you've appropriately resuscitated with fluids, I also will jump and start to put an infusion of a pressor on that works best, because some of this stuff is just short acting, and you're able to hopefully buy them some time as far as renal perfusion and critical or vital organ perfusion. But you need to balance that and look at the whole picture. So this is what's really imperative about HIPEC cases, is that you're not balancing or managing individual variables. You're looking at the whole picture and how each of these synonymously affect one another. And sort of, it's really about, management in motion, if you will. The other thing is managing some of the, I'll make a point here related to some of the other things to consider when you're sending off labs is blood glucose. We have a threshold of when patients get to 150, we're okay. Anything above 150, we start insulin infusions to keep them below 150. That's an imperative. Obviously, if your calcium levels are trending downwards, if your hypokalemic, so potassium levels need to be optimized. I will also tell you, in these types of cases, it is best for an epidural. And so during these cases, I will run free bupivacaine 0.125%, and I will titrate that. So here you got another variable, right? You're loading up that epidural with bupivacaine, and what happens? They get vasodilation with that. So I tend to try to gradually increase that over the case, pending their sort of hemodynamic responsiveness. My goal is to try to get about 60 cc's to 80 cc's of 0.125% before the end of the case. I don't tend to like the epidural pumps in the operating room that's got the concoction with, hydromorphone. I'd rather do that myself separately and then let that and get them well dialed in before I wake them up at the end of the case. Now, this is something else too, right? So you've got all this stuff going on. There are a lot of places that still bring their patients to the ICU. I haven't brought a patient to the ICU now for HIPECs in probably 15 years or more. About 15, 17 years. We don't go to the ICU anymore. We extubate in the operating room. I tend, once they have the muscle layer closed and they start working on the fascial, and just before they get to sub-Q and skin, I start to move them towards getting them back breathing. There's a bit, and it depends on what you're running as far as your anesthetic. I typically will run a TIVA, so that TIVA involves propofol infusions, ketamine infusions, dexmedetomidine infusions. There is this misnomer out there that patients should only have about 100 mics of dexmedetomidine intraoperatively because they won't wake up. That is false. 110% hogwash. It's not uncommon for me to give my patients 200 to 300 mics of dexmedetomidine. What the key is shutting that dexmedetomidine off at least 2 hours before you want to pull that tube. That way, that threshold is redistributed. I've given 80-year-olds 300 mics and they wake up fine. In fact, we pull the tube out. They actually are thanking the operating room for taking care of them at the end of the case. So it can be done. You just have to pay attention. Similarly with ketamine. I used to minimize the 50 mics, but you're doing these cases that are 10 to 12 to 14 hours in duration. And so I don't have a problem if they consume that entire 200 milligrams. It's fine. It's distributed over the course of the case. I do not run it. Same thing with dexmedetomidine is that 2 hour frame before extubation. So I got that stuff off. And then I'm basically manipulating propofol. Sometimes I'll run a little bit of gas just to kind of give me some coverage based on what the EEG waveforms are telling me. But once you get into that sweet spot, the muscle layer, so that's the proline. Once that proline is in and now they're on Vicryl pops, as they're closing with Vicryls, I usually wait till about 50% of that being closed before I start to actually try to start working and weaning them back to breathing during the case. Once they start breathing, I'm also in conversation with the surgeon, telling them, here's what your lung compliance is, here's what the peak inspiratory pressures are, the patient's going to start breathing, I'm trying to get them back. And I let the surgeons know so I can get the pain management under control before we pull the tube out. And invariably, by the time they're putting the dressing on, the tube is now coming out. And I now have a face mask on them with an O2 tank, and everything else is off, and we are done the procedure, and we go over to the PACU nice and comfy. So that's kind of a little bit of a reflection on sort of the anesthetic approach. These cases are really fun if you get engaged and, recognizing what fluid shifts are and how to be proactive. So, that's kind of been a long, detailed, deep dive into HIPECs. That is a little bit intentional because HIPECs are a type of case that we perform that require a significant level of attention and approaches. So if you're ever preparing for one, I encourage you to walk through this mentally before you even start the case. Think through each phase and what each phase you're going to need to keep in the back of your mind and being proactive versus reactive. And I don't want to tell you that even after 24 years that I don't get behind sometimes, because I do. It gets frustrating when you get behind, but that's very few cases. The other is the physiologic shifts. Anticipate that. It's going to happen. What are you going to use? For a pressor, it's not just ephedrine and phenylephrine. Do you have octreotide? Do you need vasopressin in small squirts? Do you need norepinephrine in small squirts? Do you need to start an infusion of either phenylephrine? And on the flip side, what are you using as a antihypertensive agent? We typically will have esmolol as well as nicardipine, calcium channel blocker, and those tend to do a good job of making sure that the patient is covered as far as hemodynamic swings. So, when you're in that OR, the more you've already thought through this and the more control you have, you'll be more prepared. Let me just talk about a little bit before I close here is what are sort of the lines that you put in. It's pretty rare we put a central line in unless there's tumor debulking coming off of things like the cava, the hepatic portal system, any of the, the iliacs, any vascular components. Then we make a educated decision whether we want to use a central line instead of 2 big bore IVs. But typically for vascular access, 2 big bore IVs and an arterial catheter is suffice for most of these cases. It's not common to get into a real big bleed. It's usually more often than not an oozing over the course of the case, but just be ready for that. And if you don't put one in, because remember, this is the cost of the patient, right? And it's not benign. Putting central lines in are not benign, even if you're using ultrasound. And so, we err on the side of conservatism, and we do fine with it. Again, we extubate in the operating room. We don't go to the ICU unless they need it, and that's pretty rare. We do go to the recovery room, and then the patient goes to overnight recovery, which is about 23 hours, and then they'll go off to the floor. So with all that, I know it was a lot, and I'm sorry Lynn couldn't join us today, but I want to thank all of you out there for joining me today on Anesthesia Alchemy, Lynn and Garry Unplugged. So I'm Gary. Stay sharp, stay curious, and we'll see you next time. And with that, please jump on over to Beyond the Mask and our clinical component known as Anesthesia Alchemy, Lynn and Garry Unplugged. Give us a like, give us a comment. If there's something you'd like us to talk about on upcoming podcasts, please drop us a line so that we'll be able to put one of those together for you. Again, thank you for joining us today, and we will see you next time.